Welcome!
Welcome to MCL Charge Capture and Coding, where I provide very informative, very resourceful medical billing and coding lectures. Hello everyone, welcome again to my vlog. I hope you have learned a lot from our part 1 video lecture on the incision and drainage procedure. For some of you who happen to have missed that lecture, I recommend that you watch that video first, then please come back with me here to catch up with today's video lecture presentation. Today's part 2 focus topic is the needle aspiration procedure. Full disclosure, the main sources of my lectures are the CMS website and our current CPT 2024 codebook. I will mention my other online references, if any, as we go along with our presentation. Note that all my lectures are from a billing and coding perspective. Also, please feel free to pause the video if you need more time to read through the information shown in your screen, and simply hit the play button when you are ready to resume with our lecture presentation. So, let us begin. AMA's Principles of CPT Coding 9th edition describes the fine needle aspiration, or FNA, as that which includes the preparation of smears when performed. It involves aspirating fluid or tissue using a long, slender needle and having the cells in the fluid examined histologically. Take note that this is different from biopsy, in which a small piece of tissue is taken and examined for histologic architecture. The fine needle aspiration codes are not specific to anatomy. Anytime a fine needle aspiration is performed anywhere on the body, regardless of the type of cells being aspirated, without ultrasound guidance or any type of imaging guidance, report CPT code 10021. When fine needle aspiration is performed without imaging guidance, CPT code 10021 is reported for the first lesion. Report the add-on code 10004 for each additional lesion to indicate that CPT 10004 is in conjunction with CPT 10021. The CPT codes 10005 and 10006 are used when the fine needle aspiration procedure is performed with ultrasound guidance. (10007) and 10008 are used when the needle aspiration procedure is performed with fluoroscopic guidance. The CPT codes 10009 and 10010 include the use of CT guidance when the needle aspiration procedure is performed. And lastly, use CPT codes 10011 and 10012 if the fine needle aspiration procedure is performed with magnetic resonance guidance, or MR guidance. For additional reporting guidelines for fine needle aspiration biopsy, including MR guidance on additional lesions, refer to the parenthetical statements under the CPT add-on code 10012. Things to remember. In reporting the CPT code 10021, the coder is confirming that the supervising physician who performed this service is a board-certified physician. This is per CMS LCD reference article 857807. According to the CMS guidelines from Chapter 3.L.12 or the Surgery Chapter on Integumentary System, Section L for General Policy Statements under Subsection 12, CPT codes 10004 to 10012 and 10021, which are assigned for fine needle aspiration biopsy procedures, should not be reported with another biopsy procedure code for the same lesion. For example, a fine needle aspiration specimen is usually examined for adequacy when the specimen is aspirated. If the specimen is adequate for diagnosis, it is not necessary to obtain an additional biopsy specimen. Do not report CPT code 76942 or ultrasonic guidance for needle placement for biopsy, aspiration, injection, or localization device with imaging supervision and interpretation in conjunction with the fine needle aspiration CPT code 10021. So, again, reminder, only if the specimen is not adequate and another type of biopsy, such as needle or open, is subsequently performed at the same patient encounter, report a separate aspiration biopsy of a distinct, separately identifiable lesion. Take note, CPT code 10022 was deleted on January 1st, 2019. Also, if removal, destruction, or other form of elimination of a lesion requires coincidental elimination of other pathology, only the primary procedure may be reported. For example, if an area of piloneal disease contains an abscess, incision and drainage of the abscess during the procedure to excise the area of piloneal disease is not separately reportable. In our Part 1 video lecture presentation, we learned of the different types of abscesses. Today, I would like to further discuss the topic on peritonsillar abscess. According to the website of National Library of Medicine, peritonsillar abscess is a collection of pus in the peritonsillar area. People with this infection may start to show symptoms like severe sore throat, difficulty in swallowing and pain on swallowing, and fever and malaise and trismus. The National Library of Medicine also stated that peritonsillar abscess is the most common ear, nose, and throat or ENT emergencies presenting to acute ENT services, and more often than not, this type of infection requires a procedural intervention as the mode of treatment. In our Part 1 video lecture, we talked about the incision and drainage procedure. Today, our focus topic is needle aspiration procedure. These two procedures, please note, are the two main treatment modalities that are presently used in the treatment of peritonsillar abscess. So, it is important to note that a case study was conducted and initially published in the website of Cochrane Library in December of 2016. The objective of the study was to assess the effectiveness and risks of needle aspiration against incision and drainage for the treatment of peritonsillar abscess in older children, like 8 years of age or older, and adolescents and adults. And the author's conclusions from this case study with respect to the implications for practice are that currently only very low quality evidence is available to determine whether needle aspiration or incision and drainage is most effective for treating peritonsillar abscess. This suggests that incision and drainage is associated with a lower recurrence rate, which means that the absence of high-quality evidence results in a dilemma for practitioners and patients. Through shared and informed decision-making, however, practitioners and patients together must balance the potential benefit of an incision and drainage procedure, however uncertain, which may be more painful, against needle aspiration, which may have a greater chance of recurrence but be potentially less painful. The unit of service for fine needle aspiration biopsy, CPT codes 10004 to 10012 and 10021, is a separately identifiable lesion, which means if a physician performs multiple passes into the same lesion to obtain multiple specimens, only one unit of service may be reported. This is a very important guideline for coders and billers to take note of. Let us talk about needle aspiration procedure versus incision and drainage procedure. The needle aspiration. This procedure uses a large bore but slender needle that is inserted through the palatoglossus muscles into the abscess. Several insertions of the needle in different locations may be performed during a single treatment episode, while the incision and drainage procedure uses a guarded scalpel to incise the palatoglossus muscle and enter the peritonsillar space or abscess. The peritonsillar space is then opened widely by dissection with blunt forceps to promote drainage of the abscess. Note that a patient with a peritonsillar abscess is sometimes treated with a combination of these methods. If incision and drainage of peritonsillar abscess is performed, report CPT code 42700. If ultrasound guidance was used, also report 76942. So that is it for our Part 2 video lecture presentation on needle aspiration procedure. Up next is our Part 3 video lecture on catheter drainage procedure. We will talk about this procedure in detail, along with its billing and coding guidelines, as well as the documentation requirements published by the CMS.